encounter. Good deal. In an ED setting and discuss treatment options, most common substance in an ED setting. So that's very timely and good. So a little bit about Anton. He grew up in New York, and Maryland. He's lived in California for a little over 15 years before he came to Oklahoma. So he's a serviceman. He's been in the Navy. He's a corpsman in the Navy. I don't know if I guess you hung out with the Marines. I'm in the Army behavioral health. I hung out with the Marines some. And I remember what they said in the Navy, smarter, not harder. So he had several deployments. So you're in Iraq?
Yeah.
Right? Yeah. So we might have crossed paths in Iraq. Who knows? And he's had several friends, as many of us in the military, who have had difficulties and suffered and struggled with substance use disorders. Anton received his bachelor's in exercise science, his master's in public health, specializing in health promotion. Did you go through the program over here at our College of Public Health?
No, I didn't. This is back in California.
Yeah, we used to have quite a few guys so when I was over there come through that program, and they'd end up in one or two of my classes. It's always fun having them. And then he got his master's. Huh? And then he got his master's in medical science, PA school, doctorate in medical science, specializing in emergency medicine or emergency management and global health. And he's taught at various schools in California. So currently Anton is at the Oklahoma City VA in the emergency department, urgent care, as a physician assistant. So Anton, we are very happy to have you. Hope you'll be coming back over the years to talk with us about substance abuse from a variety of different aspects as a part of the VA. So I'm gonna be quiet now and turn it over to you. So thanks.
Of course. Thank you, Dr. Brand. So again, thank you for the introduction. I am a first-time presenter for this seminar with you guys. So bear with me. I want to go over some things just kind of from my standpoint as a PA in the ER setting, dealing with substance use disorders. A lot of times they come with other issues on top of that, but I'm just going to bring up my slides here so that way you guys can see that. I'll make this bigger. Hope everyone is enjoying their Friday. This has been a busy day for me. But so I'll go ahead and get started. Dr. Brand, just to kind of time myself, do I have 30 minutes or an hour? How long do I have to go over this? I just wanted to clarify with that.
Yeah, we usually go to about 3. So if you're unshort, you like to get the weekend started early, but if you run right up to 3, and usually we ask have a little bit of time at the end for questions if people have certain kind of things they want to bring up, or you can stop during the middle, whatever. But usually the recording goes off about 3 o'clock.
Okay, sounds good. Thank you so much. So just to go over my slide. So again, substance use disorders and the role of the emergency department. Most people will see the ER as kind of a first place to go in an emergency situation or just an immediate need. So substance use disorders are typically something that people will come in for, whether it be for alcohol use, or some type of opioid, but we'll get into that here shortly. So objectives, again, defining the role of the ED in evaluating patients with substance use disorders, identifying and describe common health effects and risks of the most common abused substances encountered in the ED setting, and discussing treatment options for the most common abused substances as well. So let's go ahead and get started. So, I'm sure most of you know what an ED is or what the emergency department is, but it's usually referred to as an ER. In the hospital facility, it's staffed with medical personnel 24/7. So, when other clinics are closed, ER is usually open. It provides outpatient services to those who require immediate care. And so the patients may arrive either on their own or via ambulance. A lot of times people will come in on their own for things that they probably should have been in an ambulance for as well. Now in the ED, we have many personnel there. There's emergency medicine physicians, PAs, and Ps. We have the registered nurses, respiratory therapists, health technicians, ancillary services such as radiology might be there, lab, other specialties or specialists from that might be on call. So might have hospital internist, ortho, ophthalmology, definitely psych at the VA will be around, or someone will be around. Licensed clinical social workers. And then we have our admin staff, and then a lot now, particularly at the VA, and I know it's becoming more common in general, having police officers in the ED just because of the increased violence that has been going on. Overall, in the ED, usually, in my experience, I've always seen it as it's a team effort. Okay, everyone's there to help patients. We're all there to do a job. Particularly at the VA, we're a little bit, we want to take care of our veterans because that population in particular deals a lot with substance use disorders, suicide attempts, and things like that. But it's a team effort. Everyone's there doing their job and doing their part. So just to kind of jump into it, so some of the most common conditions we'll see in the ED, and this doesn't necessarily have to do with substance use disorders specifically, but these are some things just in general, especially since the pandemic started. Obviously, there's exposures to COVID-19, people with chest pain, dyspnea or like shortness of breath, abdominal pain. They can have acute upper or lower respiratory issues, fevers, headaches, nausea, vomiting, diarrhea. You can see the rest of that list. Kind of want to point out, obviously the behavioral health issues, weakness, syncope, overdose, and altered mental status. Now I have these highlighted in yellow. Hopefully you should be able to see that. Primarily because me looking at some of these, there's a lot of times as a clinician, you'll see as a chief complaint, someone coming in with some of these conditions, particularly like weakness, nausea, vomiting, abdominal pain. Some of these, I see these, and somewhere in my differential, I'm wondering, is there a substance use concern here from alcohol or marijuana? That happens a lot, especially with the nausea, vomiting. So that's why I have these highlight in yellow for some of these conditions, and it can really be for other things too. So what is a substance use disorder? What is that? So substance use disorders, or SUD, we'll refer to it as that moving forward, are chronic illnesses that are characterized due to recurrent use of alcohol and or other drugs. Singular or again in combination, which significantly impairs aspects of a person's life that may affect their social, occupational, recreational, relationships, and health complications. So individuals that usually experience SUDs may have concurrent mental health issues. So they may be suffering from anxiety, depression, ADHD, bipolar disorder, and schizophrenia. So it's kind of a multifaceted issue, not just related to the consumption or use of substances. So some key risk factors and symptoms that might have someone be more susceptible to substance use disorders. Risk factors being hereditary. Mom and dad drank or were used drugs. Environmental factors, where they grew up, they may have seen a lot of people engaged in use of marijuana or drinking at a young age. And mental health disorders as well. Again, that can be hereditary linked. And some people might not know they have mental health issues that are actually diagnosed. So symptoms of SUDs: daily use of a substance resulting in urges that require need. Okay, so if they can't get through their day without, I need a cigarette, I need a drink, I need a bump, SUD. Taking or needing more of a substance to get the desired effect. So that threshold is to get the high that they're needing or to get the sensation of feeling a buzz or getting drunk. They need more. Okay. Decline in social, occupational, or familial responsibilities. So if their life is spiraling down the drain as they continue to partake in whatever substance that they are partaking in, these are things that that you might see that will make you think, okay, does this person have a substance use disorder? Performing more risky activities when under the influence. So unprotected sex, drunk driving, handling of weapons, or violence. Those are all things that may point to that. And then experiencing withdrawal symptoms. We'll see that a lot in the ER of people going through withdrawal and they don't understand why. They might have headaches and palpitations and nausea, vomiting, but they didn't, they think they ate something, but they're really just going through withdrawal. So in the ED, or in the emergency department, our top 5 drug-related visits, usually, and this is just generally, number 1 would be alcohol. That's probably across the board. Alcohol is probably, or is the top drug. It is a drug, even though it is a legal drug, technically. Then we have our opioids. So within that category, aside from prescription opioids, there's heroin and fentanyl. And we have probably all heard the news with fentanyl and the continued rise in issues with that. Okay. Methamphetamines, marijuana, and cocaine. So those are kind of the top 5. There are other substances, obviously, like psychedelics and things like that, but these are essentially the top 5 that we'll see in the ED setting generally. I have a video here, and it's kind of old. I want to see if it'll actually play. It's kind of janky, so bear with me. Okay. So this video, I didn't want to use like actual people's faces, or some of them were too long, but kind of the things that would be someone seeking, a drug seeker in particular, in the ER. So this is just a video I found that would be kind of interesting to give you an idea of what we hear. If you guys can see it, let me know, or give me like a thumbs up if you have your camera on, or just type in yes, just to see if you can see it, but you should be able to hear it.
Hey, Anton, I don't think we can hear it or see it.
Can't hear it or see it? Okay.
When you go to your share screen, I think Kelsey to, and look at the bottom left hand, and there may be a thing that says show video or something like that, or sound. And if you click those boxes, it may work. Kelsey, got any help there? The lesson she taught me here some time ago.
Yeah. Well, if it doesn't show up, that's fine.
Let me see just a second. Hold on.
If not, it's fine. I can give a brief description of what it is, because I don't want to hold that up. It's just kind of a funny video on drug seeking type behavior that people will come in for in the ER.
Yeah, whatever you want to do, it's fine.
Yeah, no, yeah, we can just, so yeah, basically it was just a video, kind of an animated video of a person coming in for requesting Percocet in the ER. They were saying their drugs were stolen and they need a refill for 120 pills. No ER is going to do that. I wouldn't prescribe that. No one I know would do that. And then he basically was making a whole bunch of excuses saying he was allergic to Tylenol, which Tylenol is in Percocet, and a few other things of drugs he was allergic to, which are kind of obvious drug-seeking behaviors, and indicative of someone that is has a substance use disorder, particularly with opioids. But sorry, I couldn't show it, but we'll move on. I just wanted to kind of break up the monotony of looking at words. So, go back to this. Okay, so can you see back to the regular, you can see, everyone can see the regular PowerPoint now. That hasn't changed.
Yes, we can see it.
So let's talk about the first one, alcohol. So alcohol or ethyl alcohol or ethanol is an intoxicating ingredient present in beer, wine, and liquor. I'm sure most of us are probably familiar with that. It's produced by fermentation of yeast, sugars, and starches. So with alcohol, excessive use can lead to binge drinking and intoxication. Intoxication is basically excessive consumption of alcohol. So if you get to the point, you know, blurred vision, things like that, you're probably intoxicated. Binge drinking, which is a pattern of consumption in which you're basically reaching a level of the legal limit, the 0.08, within a short period of time. So if you reach the legal limit in about 2 hours and you're binge drinking, that's basically an acute intoxication. That's kind of where that falls under. So some of the health effects, symptoms, risk of alcohol use is impaired brain function. So things get a little blurry. Your reaction times slow down, things like that. Dilation of the blood vessels resulting in rapid body heat loss. So when you drink and you think, oh, I feel warm, you know, your blood vessels are actually, you know, they're dilated. That's why you feel like that, but you actually lose body heat a lot faster as well. So if you go out and drink and you know, are having a good time, and it's cold out like it is now, you're probably going to get a lot colder a lot quicker. Chronic diseases such as cirrhosis, which is very common with alcohol use, that will damage your liver. Acute and chronic pancreatitis. A lot of times patients will come in with pancreatitis after having a binge drinking situation or drinking all weekend, like on a holiday weekend, and have nausea, vomiting, abdominal pain that's severe, out of proportion, or maybe not out of proportion, but it's very severe for them, and it's likely due to their drinking. Cancers of the oral pharynx, esophagus, and liver are all chronic issues, as well as hypertension, so high blood pressure, cardiomyopathy, which is basically stretching of the heart muscles or enlargement, arrhythmias, and stroke. Can also lead to or exacerbate mental health disorders. And in pregnant women, increase risk of fetal abnormalities. And another risk, or actual risk, is obviously motor vehicle accidents. Increases the risk of those, as well as interpersonal violence. Because you can think how many times you've seen people that have gotten drunk and, you know, they want to fight someone, and, you know, something worse can come of that, obviously, but a lot of times situations like that usually involve alcohol. So alcohol use disorders So with each of these, there's kind of a use disorder. This is just within. Obviously, this is all a substance use disorder of these most common ones. But with AUD, not all excessive drinkers meet clinical criteria for severe AUD, which is a chronic disease. But typically, if they have, again, inability to limit themselves, so if their drinking habits continue, they're not able to stop, or they need more, that's a sign. Continuing to consume alcohol despite personal and professional problems, that kind of rolls back again. They need to drink more alcohol to get the same effect, and the inability to think about other activities or responsibilities due to the urge or want to consume alcohol. So overall, these are still just within alcohol use disorder. You know, it sounds familiar with just SUD for all substances in general. Opioids. So these are a class of drugs that are used to reduce pain. We are having a national crisis with this right now, or health crisis with this because of continued use of opioids. But they are naturally found from the opium poppy plant. So, you know, opium has been around for centuries, millennia, however long they've used it in other forms of medicine, like Chinese medicine, Eastern medicine, and things like that. So it can come from the plant or synthetic. Of the three, of these, there are 3 subclasses of drugs that fall under opioids that are concerned for SUD. Those are prescription opioids, so things like Oxycontin, hydrocodone, morphine, and methadone are examples. Fentanyl and heroin, so the ones I mentioned previously. The rise of opioid prescriptions, particularly in the 90s, excuse me, resulted in 3 waves of opioid overdose deaths, in which between 2019 and 2020, since then opioid involved deaths have increased by 38%. So there's still an issue with this. You know, it's 2023 now. There's a continued issue with opioid prescriptions. A lot of times people will come in for these wanting pain for, you know, first thing they ask me for is, oh, I sprained my ankle, can I get some hydrocodone? No, you cannot get hydrocodone for your sprained ankle. Sorry, that doesn't qualify. For me, that's excessive and just can lead to other things. So health risk, health effects and risk again. So kind of the symptoms here. So how opioids work are they bind to the opioid receptors in our central nervous system and other organs that ultimately block that pain signal, releasing large amounts of dopamine throughout the body to relieve pain and feelings of euphoria. So a lot of the drugs that are used, you'll see dopamine a lot. Dopamine is one of the neurotransmitters that are affected with pain medications. However, harmful effects include you have the drowsiness, confusion, nausea. Constipation is actually really big too. For people that do use prescription opioids for chronic and severe pain, that's one of the things where I always tell them, like, you know, expect constipation with this medication. I might give them a stool softener or Metamucil or something like that to kind of help them if they have that issue with constipation. And then bradypnea, or slow breathing rate. So the major risk with opioids in particular is that last one, that slow breathing rate or respiratory rate, which can lead to hypoxia due to that. And that can lead to coma, permanent brain damage, or death. Okay, so like with fentanyl, that's the concern in particular with fentanyl, is that breathing rate, respiratory rate goes down gets too low and slow, that it can lead to hypoxia. You're not getting oxygen to your brain. Methamphetamines. So these are powerful drugs that are, again, affect the CNS nervous system. Chemically, they are similar to amphetamines that are used to treat ADHD and narcolepsy, so like Ritalin, for example. Those medications are kind of along that line, but obviously not methamphetamines. They're usually ingested. They can be smoked, can be snorted and or intranasally, and then or put in a liquid form, injected. They increase, again, the amount of dopamine in the brain, which is involved with motion, locomotion, motivation, and reinforcement of rewarding behaviors. So that last part of that is also important with the dopamine release, and why people continue is because of that reward factor. So with methamphetamine, this has quite a few health effects, short and long term, as well as just risk in general. So there's the increased wakefulness, decreased activity, tachypnea, or so rapid respiratory rate, arrhythmias, hypertension, and increased body temperature. Can lead to chronic infectious diseases, so hepatitis B, hepatitis C, HIV, particularly if you're injecting as well. That can also be an issue with heroin. Extreme weight loss, addiction, obviously, dental issues. I've had patients where they are long-term methamphetamine users. I probably don't even need to know that part of their history, and can tell by looking at their teeth that they've probably done methamphetamines for a long time. Itching. Itching is another one where I can probably tell, if looking at them, if they have kind of like sores all over their body from scratching, that probably haven't come from anywhere, and sometimes they get infected. That's something that I see that I suspect, oh, this person may be a methamphetamine user, because they have sores like on their face, on their their arms, their chest, different areas of their body. And usually they swear up and down it's something else, because they don't want to, or they either do or they don't want to admit that they are a drug user. Then obviously there's some issues with anxiety, there's confusion, they have memory loss issues, they're excessively paranoid. I will say that, very paranoid, especially when they are, when they've recently used. And I'm sure some of you have probably come across that or seen people that are very paranoid, may have been on methamphetamines at the time or recently. Hallucinations and violent behavior. And usually that violent behavior is very sporadic, and not provoked from very minimal things. So methamphetamines can cause changes in the dopamine system, again, that will affect coordination, verbal learning, memory, and emotions with long-term use. So these people, over a long period of time, they will have just issues with their neurotransmitter biology in general. It's just all out of whack. I've come across a few people like that as well, and they're relatively young, maybe mid 40s. I have a few patients that I see regularly that are maybe mid 40s, early 50s. And I mean, they look and speak as though they've been on drugs for a very long time, and speak in a manner that you wouldn't expect them to. So moving on, marijuana. So marijuana, as we all know, is, I didn't know this actually before moving to Oklahoma, with your boss here now. Very popular drug. It's from the dried leaves and flowers and stems of the cannabis sativa or indica plant. It contains mind-altering chemical, or THC. Typically, it's smoked or vaped, but its extracts can also be used in edible forms. So like the edible gummies or brownies or whatever else is out there, whatever else they're cooking up. So health effects from marijuana. So when smoked, THC passes from the lungs to the bloodstream. That THC acts on the brain cells and acts on the specific receptors that are similar to THC chemicals. And they basically affect that, that high sensation, okay? So when people are high from either smoking or eating, they can have altered senses, change in mood, impaired body movement, impaired memory. I swear whenever I see someone that is clearly high, they don't remember smoking, but which is surprising to me because maybe they just smoke too much and I can smell it on them, or they're just lying. Hallucinations, delusions, psychosis. Here's that intense nausea, vomiting. I had a elderly woman that had intense nausea and vomiting. She couldn't understand why. Well, she knew, but I eventually got it out of her. Grandma was smoking weed with her grandson, and she got very sick. And I want to say, if I recall correctly, that was her first time. Didn't end well for her, or not her. I think her first time with that particular strand or whatever. But the intense nausea and vomiting is something that is pretty common. Respiratory issues are another one. Elevated heart rate, so they might also be anxious. And then long-term use may affect brain development and cognition in individuals during pregnancy. And lastly, cocaine. So cocaine is a powerful stimulant. In the past, again, this is another drug that has been around for a long time, used in elixirs and medications and tonics for illness. I think Coca-Cola got its name originally from having Coke in it. Cough syrups back in the day. But today it is a Schedule II drug with a high potential for addiction and abuse. Cocaine, again, increases levels of dopamine. However, prevents the recycling of it in the synapses. So if you imagine the two, the beginning and end of a new nerve, it builds up in that space. So it doesn't recycle, it has nowhere to go and it just builds up. Then cocaine is used in two ways, typically intranasally or smoked. I know people do it, like put it on the gums or on the oral mucosa as well, in which it can be absorbed. So with cocaine, people typically have extreme happiness, a lot of energy. They're very alert mentally and hypersensitive to everything. That can easily change from that to being very irritable and having paranoia. Obviously, they can have some nausea, some vomiting issues. They can have arrhythmias, tremors. One of the things we'll look for in someone you on cocaine or suspect cocaine use, we'll check their pupils if they're dilated, along with all these other symptoms. And then hyperthermia, so again, that elevated body temperature. So long-term effects, again, it kind of depends on how, with this one, it kind of depends on how it's used. So if someone is doing it intranasally or snorting, mostly, or they're doing it for a long time, They can lose their sense of smell. They can rupture the mucosa in their nasal septum. They can, if they're doing it orally or putting it in the oral mucosa, they can, again, there could be breakdown in that tissue. The gingival line can break down, exposing their teeth more. They'll have dental issues. So there's a few things with cocaine where it kind of depends on how it's used. So what is the ED role in managing SUD? So ED has long been kind of utilized or recognized as a critical. For people that don't have insurance, they have no primary care provider, they'll go to the ER. I see it all the time. I see so many primary care things. It's, for some of us, it's annoying, but I get it. But it's things that they should be seeing a primary care provider for, because it's more chronic issues that would need to be addressed versus the emergency room. But that's also why we're there. So, over the last few decades, we see, it's obvious the link is there, but for patients with substance use disorders, they can also receive appropriate care there, or at least initiation of care. Patients with SUD will regularly visit the ER for either substance use disorder issues or SUD or something related. They'll regularly see substance. So in the ER, there are things where someone will come with a soft tissue injury, or obviously an overdose or something like that, that may or may not correlate with their actual substance use disorder, but it may be a starting point to get that person the care that they need. So like at the VA, for example, a lot of times, and especially during the holidays, it happens, the incidences occur more. People will come in, suicide attempts or suicidal ideations, substance use. And at the VA, it's a little bit more established, I think, because we have those services there. They know to come to the VA if they have those thoughts of, if it's a mental health related issue that was also on top of them drinking or doing a lot of drugs, they know to come to the VA because we can get them care there, not necessarily having to refer them out somewhere else, typically. So like at the VA, we have our licensed clinical social workers in the ER. So if I'm on the tick and someone comes and I see it is a overdose or a substance related issue or a mental health issue, I'll interview them, and then we kind of double team with the medical standpoint and then the behavioral health standpoint of the social worker being there, and then deciding if this person needs to be admitted, or if they're voluntarily wanting to be admitted for rehab services to help them get back on track with either decreasing their use of substances, whatever that substance may be, or interventions for mental health issues that they have as well. Typically, substance use disorder patients have a higher likelihood to return to the ED for new or similar complaints within 72 hours. So we do have, so there are things that we, as the ER departments or emergency departments, there's no like set policies for recommendation for broad interventions or referral treatments. It's usually kind of hospital dependent. What I've become accustomed to. There are screening tools that are validated that we use. So like the NIDA quick screen, where they'll ask a patient, how many times in the past year have you used an illegal drug? Usually that's done via triage with the nurses up front. And, depending on what their answers are, this is kind of an example of the NIDA whether it's alcohol, tobacco, or illegal drugs, and their usage. So whether never to almost daily or almost daily. So getting to the intervention part and treatment. So like from the VA, like from our standpoint, we can kind of get them in and we can get them in there that day and admitted for treatment services there. Now there are two sides to that. We need to have medical care and mental health services involved. So one in general with intervention is just recognizing the problem. And then, if they're wanting to seek professional help, that's why they're there. The initial assessment to determine the level of care needed. Detoxification. So usually these people are coming in with substance use disorder concerns or complaints. They're wanting detox. That's that step that they're coming into they come in to get evaluated and they're coming to be admitted for detox. And then after detox, there's behavioral health counseling, there's peer support, there's medical management or continued medical management with medications that are either for their mental health or for helping them with their addiction as well as their mental health. And then relapse prevention planning. So the medical management, so I just kind of gave like a quick example of like a patient that's coming in for treatment SUD in the ED will begin with medical management. So a 28-year-old coming in with complaint of anxiety, palpitations, and nausea, vomiting. For hours, has a history of drug use. Kind of a quick workup that I would look at getting for suspicions, and then my initial treatment. And then from that, that tox screen is the big one because people will say, oh, I smoke weed. And then you find 4 other things on their tox screen. So treatment in the ED may also be rendered for those on overdose or going through withdrawals. In an overdose scenario, naloxone or Narcan can be used quickly to restore normal respirations, wake the patient up, for example, if it was a drug-related issue for their overdose. Well, obviously it's for their overdose, but if it was suspicion of overdose. And that can be used for heroin, fentanyl, cocaine, and methamphetamines. If you use Narcan on a person that is ODing or they're unresponsive and you suspect OD, they're not gonna wake up happy. Let's just say that. They will curse you out. They may not know where they are, but it's always an experience whenever you're waking someone up using some Narcan. So particularly for the substances to prevent relapse during the medical management of SUDs, there are medications for opioids and alcohol addiction. So for the opioids, we have methadone, which acts on the same receptors as the opiates and suppresses withdrawal, symptoms, and craving. Buprenorphine, and which is similar to, or has the same, basically there's the same thing as methadone. And naltrexone, which blocks the effects of the opioid at the receptor site during the but it has to be used after the detox phase. So recently, so with like addiction medicine, recently you basically have to, as a clinician, you have to have a X waiver basically on your DEA, which is what allows you to order controlled substances. And that was recently, the X waiver allowed you to order substance use disorder drugs, so like buprenorphine, for example. And that was recently disregarded as of January 12th, I believe, where clinicians that have DEA's registrations no longer need to have that because it was kind of a hindrance because you had to go through this class. I remember going through it in 2019 or something like that to get that X waiver to use buprenorphine if I had to. I haven't had to personally order any for anyone in a while, but that's there was like requirements that you had to have for it, but now that's gone, and it kind of takes away the barrier for people to actually receive medications for substance use disorders. Next, we have for alcohols, again, you can use naltrexone. There's a acamprosate, which reduces symptoms of long-lasting withdrawal, and then disulfiram, which interferes with the breakdown of alcohol, and basically causes an unpleasant reaction to you drink if you attempt to drink alcohol. So if you are on this medication and, oh, you know what, I'm gonna have a glass of wine with dinner. Nope, probably a bad idea because you might not feel great afterwards. Okay. So with treating SUD, just like kind of with dealing with mental health disorders, not just medication is always the goal. You also want to look at therapy. So ED can be utilized for patients with SUDs to seek resources, again, that I mentioned, in particular for outpatient or inpatient behavioral treatment therapy. So these resources and recommendations can be provided by the social worker that might be on staff in the ED or the on-call psychiatrist. So in the outpatient setting, we have CBT or cognitive behavioral therapy. There's multidimensional family therapy, motivational interviewing, and motivational incentives. And then there's the inpatient treatment, which is therapeutic community, short-term residential treatment, and recovery housing. So for the outpatient options, CBT challenges and reconstructs unhealthy thoughts, which influence behavior. The multidimensional family therapy is primarily for adolescents to kind of focus on familial function, relationship, and improve family dynamic and communications. Motivational interviewing, which basically is an approach to help address or change destructive behaviors and explore why they do that. And then motivational incentives use positive reinforcement to encourage abstinence from drugs and alcohol. And then we have the inpatient options. So there's the therapeutic communities, which are structured for participants to remain in residence for 6 to 12 months. I don't think I've dealt with anyone recently that has been through a program like that, but they're out there. I've had or dealt with people more on the short-term residential treatments, which are the long program that helps to basically medically monitor detox and prepares them for the community-based care, in which they may go to a recovery house, which is supervised, excuse me, short-term housing for inpatient residential treatment. And it basically helps get these people back into a normal life, essentially, where they can take care of themselves, their finances, and their families. So basically just conclusions on that. So the ED is important. It's basically the de facto medical care access facility. There are opportunities for improvement in programs that are effective in the ED in terms of SUD, which includes updated screening tools, additional education for the providers in addiction medicine. However, in many cases, the ED is a great initiation point, particularly for people that might not have access to medical care in general, or may never have had it, and ultimately help them fight this ongoing issue with their substance abuse. So other than that, those are my references. Any questions?
Hey, Anton, you might want to put share in there so you can see the folks who are participating. But I had one question that may stimulate some more, and that is, for a lot of guys who folks like myself who are not prescribers, and particularly medical, you got any kind of points on, when somebody says, oh, I've been drinking and I'm gonna quit, it's like, no, don't do that, or yes, do that, or opiates or meth, or you got any kind of guidance on how to kind of assess severity of potential withdrawals and kind of responses?
So when I have people that say they want to quit, for me anyway, I usually at least give them resources to, instead of saying, hey, you know what, it's great. I encourage them, it's good that you want to quit drinking as much as you are drinking, or just quit entirely. I don't recommend just doing cold turkey. I know for some people that may work. Short term, it might not last long term. But I usually give them resources to seek counseling, kind of help them go along that path to quitting. There are tools, I can't remember it right now, that can be used. I don't always access them. Where you can kind of determine the severity of, this person is a, mild drinker versus a heavy drinker versus a, severe or whatever. But I don't really use those that often because I just don't usually have the time to go through that process with them. But I would say definitely at least getting them the resources to counseling. And especially in the ED, since we have the clinical social workers there, they're a great resource. I always, like, whenever I have a mental health or substance use issue, I always kind of confer with them also to see, hey, what do you think about this? Because this is what I'm thinking, what are our next steps? Because especially for me out here, I'm still new to the area generally, because I've only been out here for about 1.5 to 2 years. So I don't know all of the different, facilities that they might be able to go to between here, Texas, or, wherever, because we have a lot of traveling vets that come into.
Yeah, thanks. That was very helpful.
Yeah, of course. So other than that, I hope that was helpful. I feel for me with substance use abuse, and actually with mental health issues, I kind of am on a continuing journey learning stuff, and I'm trying to do additional credentials to deal with that more as a clinician, because just from my experience and having people in my past, in my life, that have had not just with drugs and alcohol, but just with mental health issues, trying to educate myself more on that and be more cognizant to maybe find things where I've seen them have this issue, but it may have not clicked before on a previous visit. Because again, I've seen people several times. Some people remember me, and then I'm like, oh wait, I didn't realize that they may have had an alcohol issue, because I was only seeing them for something that wasn't really related. And that's, as I mentioned in the presentation as well. So I hope that was helpful.
Yes, I thought it was. Any other comments or questions? Dr. Fink, you look like you got something to say.
Yeah, just thanks a million for your talk. I'm also super happy to meet you virtually, and would love to potentially follow up. I came here also about 1 year ago from the University of New Mexico, and had colleagues in the emergency department who participated in clinical trials, network trials from NIDA, and so worked closely with them on those things, especially starting people on buprenorphine who were presenting with withdrawal, and getting them over to treatment and things like that with us. So it's great to make your acquaintance, and thank you so much for your time today.
Of course, thank you. I appreciate that.
So Anton, one thing before we go, and some people it's okay, some people it's not, and it's okay if you just tell us yes or no. But would you mind if Kelsey took your presentation, PDF'd it, and then made it available for folks?
Yeah, that's fine.
Okay, good. I'm sure there'll be some folks who are looking for that PDF presentation. So this is very good. Thanks.
Of course. Thank you guys for having me. I appreciate it. I'm trying to,
Good. Well, we appreciate it again. Thanks everybody for logging on, and we'll see you next week. Have a good, safe weekend. It'll be nice and warm and won't be icy. So get outside, do something fun. All righty. Thanks. Y'all have a good weekend.
Bye-bye.